Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. This month, the Spark theme relates to vaccines for children. I'm Paula Robeson, and I'll be your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin and Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made in shaping and strengthening this country, our province, and the country. Today, we are delighted to bring you influences on parent decision-making regarding COVID immunizations for their children. And I'd like to introduce our speakers today. Dr. Shannon Mcdonald is an associate professor in the Faculty of Nursing and an adjunct in the School of Public Health at the University of Alberta. Her clinical background is in pediatric nursing, with research training in nursing, public health, and epidemiology. And her research focuses on supporting immunization best practices and policies, and she has a particular interest in addressing system-level barriers and supports to achieving high immunization coverage in underserved populations. Robin Humble is a PhD student in the Faculty of Nursing at the University of Alberta and an instructor in the Faculty of Nursing at the Campson College, Victoria, BC. Her clinical background is in women's surgery and public health services across diverse settings and includes research experience in nursing student practice, child health, and epidemiology. And her current research focuses on how the COVID pandemic has affected parents' perceptions and uptake of routine vaccines for their children, and creating inclusive and accessible immunization services across underserved populations. Just a reminder that we're recording this webinar, and as mentioned in the introductory video, please type your questions into the question box at any time. I'll prompt you via the chat as well, and I'll pose your questions to our guests following the presentation. And it's now my pleasure to pass the mic to Dr. Mcdonald.
Good morning. Can I confirm that you can hear me okay?
Thank you.
Thank you. Well, good morning, everybody, and thanks for joining us today. My name is Shannon Mcdonald, and I'm joining you from the Faculty of Nursing at the University of Alberta, which is located on the beautiful, colorful tree-lined land of Treaty 6 and Métis Region 4. It's a beautiful fall day out there. So today we're going to share with you about influences on parent decision-making regarding COVID-19 immunization for their children. And I'll be sharing this presentation with a PhD student on my team, Robin Humble, who will be speaking a bit later. So the plan for today is to talk a bit about the COVID-19 vaccine rollout in Canada, and hit some of the sort of highlights of where we've gone and where we're going. The factors related to COVID-19 disease, the vaccine, and other related concerns that parents are faced with when deciding whether to get their children vaccinated. We'll report on results of a national study we conducted of parents of various identities and backgrounds regarding their perceptions about COVID-19 disease and vaccines, and the characteristics that are influencing their intention to immunize their children. Then we'll show how that intention has played out in practice, specifically how things are going with uptake for children 12 to 17 years old. And finally, we're going to talk about how this research can assist us in supporting parents in their decision-making for their younger children coming up and to foster inclusive and accessible COVID-19 vaccine services for children. So first of all, here's the timeline of some of the main vaccine rollout landmark dates. And we've highlighted the ones related to children. So as we all know, initially there was limited vaccine supply, which meant that vaccines were made available in a stepwise way based on a prioritization framework. In December 2020, vaccines first became available to adults in prioritized groups like healthcare workers and seniors. And then in April of 2021, most provinces started vaccinating adults 55 years and older. By early May of 2021, the general population, 18 years and older, were able to be vaccinated. And then in late May of 2021, most provinces started making the vaccine available for 12 to 17-year-olds. In late October or November, we anticipate that the Pfizer vaccine will hopefully be approved for children 5 to 11 years old, with hopes for a rollout in late 2021 or early 2022. We're not sure if and when they'll be available for children 6 months to 4 years. Those clinical trials are still ongoing, and there's no plans to make the vaccine available for children under 6 months, as they haven't been included in any clinical trials. So next, I'm going to discuss some of the factors that influence parents' decisions to vaccinate their children against COVID-19. Parental decision-making around COVID vaccination involves all the usual aspects of decision-making about vaccines in general, plus a lot of additional issues that are quite unique to the COVID situation. There's numerous models or ways of thinking about the influence on vaccine uptake. One of the more holistic models has been developed by Cornelia Besch and focuses on this, what they call the psychological antecedents of vaccination, which they refer to as the 5 Cs. So this is basically the 5 influences on vaccination behavior. And they include confidence, meaning trust in the effectiveness and safety of vaccines and the system that delivers them. So that includes trust in healthcare workers, government, public health officials, etc. The second aspect is complacency, which refers to the perception that the risks of the disease are low or that vaccination is not seen as necessary. So the degree of complacency. The third is collective responsibility, and this refers to that willingness of someone to protect others by getting vaccinated and contributing to what we call herd immunity or community immunity. The fourth is calculation, which is the extent to which individuals engage in extensive information search, weighing the benefits and risks of the vaccine and the disease. And the last is constraints. This refers to structural and psychological barriers to vaccination, things like the physical availability, the affordability, the geographic accessibility of the vaccines. So as depicted here, the 5 Cs funnel through this filter of social context in which people exist and influence how they perceive all those 5 Cs. The funnel ultimately determines which way the scales tip in regard to whether they get immunized or not immunized. So in the case of the COVID-19 vaccine, the pandemic and the rollout of the vaccine has added this additional layer of complexity to what is already known about the determinants of vaccination. Parents are dealing with all sorts of additional factors when they're thinking about vaccinating their children. The first of these is COVID disease-related considerations. For instance, parents hear constantly changing messages about children's risk of contracting the virus. Is it high? Is it low? What is the likelihood of severe illness from the disease? There's also evolving evidence and messages about the likelihood of transmission in schools, at recreational activities, and the risk to family members who might be immunocompromised. Then there are the COVID vaccine-related considerations that parents are thinking about. So mRNA as a new vaccine is something that is on people's minds. Potential side effects and adverse events. You'll have seen in the news that some vaccines have a low risk of myocarditis, and how does that balance with the risk of myocarditis from the disease itself? And then there's a plethora of misinformation on social media that parents are trying to sift through in order to discern the right decision. Then there's considerations like whether there will be vaccine mandates that influence children. And we've seen some of that already. So it might occur in a school setting, some social or recreational activities. I know myself, my children play soccer, and at this point, the children don't have to be vaccinated, but the parents who want to attend do. So those are the sorts of things that people are facing. Also, whether or not the child would have to be vaccinated to visit a family member in a hospital or long-term care home. The issue of consent is also a topic of conversation for parents. Parents, of course, feel a responsibility for this decision on behalf of their children. Some parents have left the decision up to their children about whether to get vaccinated. In other cases, there may be children who want to be vaccinated against their parents' expressed wishes. And we've also seen instances where each parent may have different vaccination intentions for their child. And there's been situations where the courts have had to be enlisted to make decisions about vaccination. As COVID-19 vaccines haven't yet been approved for children less than 12 years old, parents are weighing all of these concerns and questions, anticipating the imminent opportunity to get their younger children vaccinated. With the return to school and recreational activities this fall, we've also seen a sharp increase of exposure and transmission of COVID-19 disease in children who are not eligible for vaccination. So the younger kids in elementary school. So our team wanted to understand a bit more about how these factors influence parents' COVID-19 vaccine decision-making for their children. In December of 2020, just as vaccines were becoming licensed, we conducted a national survey of parents across diverse identities and backgrounds, and we asked them about their perceptions about COVID-19 disease and vaccines and their intention to vaccinate their children. A repeat survey is in the field right now, with the results anticipated in a few weeks. This study is part of an ongoing project funded by a CIHR grant with additional funding from the Canadian Immunization Research Network. And the team includes researchers from 6 provinces, as well as knowledge users from the Secretariat of the National Advisory Committee on Immunization, as well as provincial public health officials. And our team includes representatives from a number of these underserved populations that we're studying to ensure that their perspectives are being honored. The project included 4 components, and I've highlighted here the component that we're going to be speaking about today. A pan-Canadian environmental scan of public health leaders was completed earlier. The survey, which we're going to talk about more, interviews with members of equity-seeking groups, and analysis of administrative data to look at the impact of the pandemic on routine vaccine coverage. So the first of the 2, what we call COVIM surveys, was completed in December, between December 10th and 24th, and the second is actually currently in the field in data collection. This was an approximately 20-minute survey facilitated by the polling firm Leger, and it included a little over 5,000 participants. We captured people from the 10 provinces. Unfortunately, no participants from the territories participated, and the sample was representative by province and gender. It included people 15 years and older who have access to the internet and can read English or French. So there's certainly limitations to these sorts of surveys. The parent group that we're going to focus on today is outlined in blue. So this was 1,702 parents of who have children between the ages of 0 and 17 years. So the findings related to parents' intentions and perceptions were very recently published in this article I'm showing you here, which was led by Robin Humble, who's going to be speaking next. So I'll turn it over to Robin.
Thank you, Dr. Mcdonald. And thank you everyone for welcoming us here today. So I'll just talk briefly about the study we conducted with parents. So we sought to explore parents' intention to vaccinate their children aged 0 to 17 years against COVID-19. And we looked at parents' perceptions of COVID-19 disease in future vaccinations. We looked at previous uptake of influenza and routine vaccines for children. And we also looked at different socio-demographic characteristics. So the objective was to assess the association of parents' COVID-19 vaccination intention for their children, and then to identify factors that influenced their decision. So the rationale for the study was that there were a few nationally representative Canadian studies that explored these topics for parents. We also recognized that we were capturing parents' perceptions at a critical time point when vaccines were not available for children and had just become available for some adults. Finally, we also recognized that understanding these factors would support the implementation of public health strategies to improve access and promote uptake in this population. So first, we're just going to look at the descriptive results from our study. And two key variables of interest were from the literature, and these have been predictors of COVID-19 vaccination intention in general. And these are routine and influenza vaccine uptake before the pandemic for children. So in our parent sample, most preschool and school-age children had received all routine childhood vaccines prior to the pandemic. And you can just see this here with the two green bars. So that's approximately 82% of our children had received all recommended vaccines before the pandemic. For influenza, 37.8% of parents stated that all of their children had received the influenza vaccine before the pandemic, and this is in comparison of slightly over half of parents who reported that none of their children had received the flu vaccine in the flu season prior to the start of the pandemic. And we're going to get back to these routine and influenza variables shortly. So this slide here shows parents' perceptions of COVID-19 disease. So looking at the yellow bars on the left-hand side, 74.2% of parents agreed that they believed that the COVID-19 disease was severe. And interestingly, only 43% of parents agreed that they believed that they were at risk for getting COVID-19 disease. And again, looking at the yellow bars to assess parents' perceptions of future COVID-19 vaccines, 70% of parents believed COVID-19 vaccination was necessary. Only 54% were confident that the COVID vaccines that would be available would be safe here in Canada. And to note, the last orange bar on the right-hand side, almost 78% of parents would not accept the COVID-19 vaccine for their children if it had not undergone prior testing in children. And just a reminder that at this time, there was no clinical trial data on COVID-19 vaccine use in children, and the vaccine was just starting to be rolled out for some adults. So this slide describes how we measured the parents' intention for their children. So if you look at the blue box on the left, the survey question is, if a safe and effective COVID-19 vaccine is available, I will get my child vaccinated. The green box is the 5-point Likert scale with responses ranging from strongly disagree to strongly agree. So children included in our study were aged 0 to 17 years old. They were living with the respondent's household. To note, parents were not asked about specific individual children, rather about their children in general. Thus, we could not capture differences between children or across different ages. So this graph here shows the distribution of parents' COVID-19 vaccination intention for their children. So in our study, on the left side of the graph, responses of strongly disagree, or neither agree nor disagree were combined and indicative of low intention to vaccinate, while agree and strongly agree responses were combined and indicative of parents with high intention to vaccinate their children. So we intentionally created this binary variable because we wanted to provide public health officials strong indicators of high versus low intention, and that would assist with targeted interventions that could address factors associated with low vaccination intention. So as you can see here, 63% of our parents in our sample had high intention to vaccinate their children, whereas 37% had low intention. So furthermore, we also compared parents' COVID-19 vaccination intention for themselves and their children. So as you can see here with the first set of blue bars on the left, slightly more parents were willing to receive the COVID-19 vaccine for themselves, and that's compared to their intention to vaccinate their children. So now we're going to talk about characteristics that were associated with parents' COVID-19 vaccination intention for their children. So this was an analysis done using logistic regression modeling. So for each of the following slides, I'm going to focus in on the blue highlighted box. So text and data on these slides that are bolded, they represent significant characteristics in our model, meaning they were characteristics that were associated with parents' low intention to vaccinate their children against COVID-19. So just looking at the center column there, the adjusted odds ratio, when an adjusted odds ratio is greater than 1, it means that the characteristic is associated with low intention to vaccinate. So the only characteristic on this slide associated with low intention were parents whose children had not received the influenza vaccination the year before the pandemic. So that means parents of children who did not receive the flu vaccine pre-pandemic were 1.5 times more likely to have low intention to vaccinate their children against COVID-19. And that was compared to parents whose children had received the influenza vaccine. So if you look just below the blue box, you'll see that in contrast, previous routine vaccination was not associated. And this finding was similar to literature we found where generally COVID-19 vaccination intention was more similar to previous behaviors with influenza vaccination compared to previous behaviors around routine vaccination. So here in the next table, we see that all 4 characteristics are bolded because they are significant. Again, just looking at the blue highlighted box, parents who reported that COVID-19 vaccinations was unnecessary and they lacked confidence in the safety of COVID-19 vaccines were 2 and 4 times, respectively, more likely to have low intention for their children. So just moving to the next blue highlighted box, here we see that parents who opposed COVID-19 vaccination for their children, and that's if vaccines had not been tested in children, were 3 times more likely to have low intention to vaccinate their children. And that was in comparison with parents who would accept an untested COVID-19 vaccine for their children. So these results demonstrate the importance of accessible research and clinical trial findings that demonstrate the safety and efficiency of COVID-19 vaccines. So finally, looking at the last blue highlighted section, parents who had low COVID-19 vaccination intention for themselves were 9.2 times more likely to have low vaccination intention for their children. And again, this is in compared to parents who had high intention to vaccinate themselves. So this finding is really important when targeting public health messages to parents regarding the importance of getting a COVID-19 vaccine for themselves and for their children. Perhaps an intervention could be a vaccination center where parents and children could be vaccinated together and at the same time, rather separate appointments. So we're just going to shift now, as one of our study objectives was to gain understanding of parents' perceptions and intentions to vaccinate their children across underserved or diverse identities and backgrounds. So we know that there is inequity in COVID-19 vaccination for underserved populations in Canada. This is also relevant, of course, for global inequities in COVID-19 vaccination. So I just wanted to tease apart the term underserved populations. So it relates to people who face difficulties in obtaining needed social and health services or care. Perhaps they receive less care or a lower standard of care. They might experience different treatment by healthcare providers, such as racism or discrimination. Maybe treatment doesn't adequately meet their needs compared to the general public. So as defined by Health Canada, indicators or examples of some individuals who may be underserved are provided here on the slide. When developing our survey, we sought to ensure that many underserved population groups or indicators were included in our sampling. So looking here at our parent sample, here are some examples of underserved populations that are represented. The N for each group is provided on the slide. I just wanted to point out that 8% of our sample included individuals who self-identified as being an Indigenous parent, 11% identified as being new to Canada in the past 5 years or newcomer, and 15% were parents whose first language were not English or French, and 30% identified as belonging to a visible minority group. So we wanted to highlight and contextualize the issue of inequity in COVID-19 vaccination and disease within some underserved population groups. This is a recent study from the United States that discusses vaccine hesitancy and determinants of vaccination among visible minority groups. So the key points from the study note that willingness to receive a COVID-19 vaccine, it varies among minority population groups. Also, that COVID-19 vaccine hesitancy is more prevalent in some visible minority groups. And the intervention that they discuss is the need for public health infrastructure directly within underserved communities. So looking now closer to home, here are a few headlines from Canada that suggest we are faced with similar issues. It is well known that vaccine hesitancy and inequitable COVID-19 disease burden among minority groups in Canada is partly due to systemic racism and discrimination. For example, the Globe and Mail article discusses how some visible minority group, essential workers in Canada, face some of the pandemic's worst inequities in healthcare, labor, and housing. So because of this, some visible minorities may distrust the government's vaccination plans. Looking at the second article, a COVID-19 outbreak in a First Nations community exposed social inequities that were contributing to the spread of the virus and a slow recovery. So doctors and community leaders attributed the issues to a lack of healthcare staff, boil water advisories, and overcrowding, and a lack of a staffed hospital. So we know that social inequities are highly correlated with historical and inherent systemic discrimination. As we are on a journey of reconciliation and as Canada seeks to address discrimination in healthcare, the vaccine rollout for COVID-19 needs to focus on serving underserved populations, especially where discrimination may inherently impact the delivery of health services. So relating this topic back to our parent study, in this table we show that some of the characteristics associated with underserved populations are highlighted here in blue. So parents who were employed part-time were 1.7 times more likely to have low vaccination intention for their children. And this is in comparison to parents who were employed full-time. Parents who spoke languages other than English, French, or Indigenous languages were also had more intention to vaccinate their children against COVID-19. So let's just move on to the next slide here. Just before we wrap up, let's have a quick look to see how parents' intention to vaccinate their children in December 2020, which to remind you was 63%, compares with COVID-19 vaccination uptake for children 12 to 17 in Canada. So parents' intention to vaccinate their children in December of last year, again, was 63%. And this graph provides the cumulative percentage of Canadians who have received the COVID-19 vaccine by age group. So just looking at the bottom of the bar of the graph, you will see that as of October 2nd, 83.8% of children 12 to 17 years had received at least one dose of a COVID-19 vaccine. And of those, 9% were partially vaccinated and 74% were fully vaccinated. If you look at the top bar, 93% of Canadians 80 years and older had received one dose of COVID-19 vaccine, whereas almost 82% of adults who were 18 to 39 years, just looking at almost the bottom two bars there, have received at least one dose. So an important takeaway from this slide is how well uptake has been across age groups, noting that there is room for improvement for adults 40 years and younger, who also may be parents and their children. And finally, as we look across the country, as of October 2nd, this slide shows the cumulative percentage of children 12 to 17 years who are fully vaccinated with a COVID-19 vaccine. So note that the data in red represents female and the black represents males. And just to let you know, we didn't choose this data or segregate accordingly, rather it's what was available to us. So the provinces and territories with the lowest vaccination rates for children are Alberta, Saskatchewan, Manitoba, and Nunavut. And the provinces with the highest vaccination rates for children are Newfoundland, Quebec, PEI, and Nova Scotia. So this slide really gives us a lay of the land for vaccination uptake for our 12 to 17-year-old cohort. And I will just pass the presentation on back to Shannon.
All right, great. Thank you very much, Robin. So we have data on vaccine. So first of all, you've seen sort of where we stand with children 12 to 17 years old, but what we have less information about is how that breaks down for these subpopulations that Robin's highlighted. So, what is the vaccine uptake in children in populations that are typically underserved? It'll be important to know how this varies for these populations because it allows us to identify groups that need different strategies for reaching them. We also don't know whether parents of younger children, 5 to 11 years old, will be accepting of COVID-19 vaccines for their children when they become licensed. The next COVID survey, which I mentioned is currently in the field, will break down a bit more on the ages. So we'll break down parents' intentions by the age of their children, as well as, again, by these socio-demographic characteristics such as ethnicity and newcomer status. So we'll have a better sense of what to expect for children 5 to 11 years, as well as those in the younger age groups. So a few key messages to end with, because it's important that we think about what can we do to promote vaccine confidence and uptake in children. Although children haven't been shown as having as severe disease as adults, there have been some bad outcomes. And vaccinating children is also important because they can transmit infection to others. We now have clinical trial data on COVID-19 vaccine effectiveness and safety in children. And more than 2 million children 12 to 17 years old have been vaccinated in Canada with an impressive safety record. Vaccine coverage for children 12 to 17 years old still has some room for improvement, as shown in that map that Robin showed you. We're really at a critical juncture here as we await approval of vaccines for children in the 5 to 11-year-old age range. Canadian parents are currently deciding whether they're going to vaccinate their children in that age group, which includes approximately 3 million people. So it could have a significant impact on the control of the pandemic. In anticipation of this, we need to proactively address parents' questions about vaccinating their children. It's essential that public health communication strategies and messaging target these population groups, promoting vaccine confidence and uptake in children and parents. Social perspectives and opinions have created significant controversy and raised various issues around mandated vaccines, proof of vaccination, and issues of parental and child self-consent. This really tech-savvy and socially vibrant population of parents is being bombarded left, right, and center by information that ultimately will inform their decision to vaccinate their children. So we need to both understand the unique needs of parents and children in all populations, but particularly underserved populations, and address the questions and concerns of parents. So we'll end there to save some time for questions, and with thanks to some members of our team who helped with the preparation of this presentation, and I've provided my contact information if anybody wishes to reach out to us after the presentation. And now I'll turn it back to Paula to handle the Q&A session.
Great, thanks. We've got a number of questions here, and so I'll just get started. Sarah asks, what is the risk of COVID transmission by the unvaccinated? For example, currently children under the age of 12 versus transmission by the vaccinated?
So it's a great question. And I'll start by saying, we're not experts in all of the questions that are going to come up. So I'm a social scientist and epidemiologist and not an immunologist. So I always like to give that caveat. So the evidence is really evolving in the area you're talking about. We're very much learning as we go about the risk of transmission as more people get vaccinated. Of course, the fact that, we have different vaccines and they've been given at different times and in different populations has really complicated that evaluation. I guess the most simplistic answer is risk of transmission from a vaccinated individual is significantly lower than from an unvaccinated individual.
Right. Thank you. Anything to add, Robin? No. Next question. Was there enough data to be able to segment by province with any sort of rigor? And if so, did you see any trends?
Robin, do you know anything about that issue?
We did. We were able to look at the provinces separately, and it had its own standalone variable. Provinces was not significant in our model, meaning that where people resided across the country wasn't associated with parents' low intention to vaccinate their children. Again, as Shannon mentioned, we didn't have any respondents from the Northern Territory. So hopefully with our second survey, we can see more trends in that area.
Yeah, I'm really looking forward to those results.
Yeah, I mean, we can see how uptake is looking, and for sure, uptake is a little bit lower in the provinces where uptake is lower overall. So I think you can look at the adults as sort of an indicator of potentially where the child uptake is trending.
Makes sense. Doreen asks, what is being done to include community leaders from underserved communities in information dissemination?
Excellent. Robin, do you want to go first or shall I?
You go ahead.
Okay. I think that's a fantastic question because the research that is being done, particularly the more qualitative research where we're talking to people in community, is really showing that the populations that still have prevailing questions and concerns and access barriers are much more likely to accept the guidance and advice of trusted leaders in their community. So that could be religious leaders, elders, community leaders, and whatnot. So I know certainly I work with colleagues in the provincial government and across Canada who are actively engaging with those people to ensure that advocacy is coming from trusted individuals. So I think it's important that those individuals are involved at every step in the process. So it's not a bunch of experts going to them and saying, this is what you have to tell people. It's important that we ensure that they're involved. So I can only speak for our own project in which we've made sure that we communicate. For instance, I often will speak with leadership within the Métis Nation of Alberta to say, here's some findings we got. What do you think? How would you interpret this? How does this apply to your community? So I think engagement at every step in the process is critical.
Obviously, yes. Thank you. What specifically have we learned about intention rates versus vaccination rates in youth that we can apply to the 5 to 11-year-olds? And the second part of that is any concerns about the new formulation that's being reviewed for children versus confidence related to adult or youth formulations?
How about I answer the second half first, if you're okay with answering the first half, Robin? Is that okay? So maybe I'll just so it's very exciting to hear that the new formulation. So for those of you that don't know, the Pfizer vaccine, which has been tested in 5 to 11-year-olds, is 1/3 of the dose of what has been given to adults, and it's shown to have comparable effectiveness actually to the full dose in the 12 to 17-year-old age group. So we know that it's effective. There haven't been any safety signals, and the lower dose hopefully will alleviate some of the issues we were starting to see with occasional cases of myocarditis in the 12 to 17-year-olds. So that was part of the rationale of reducing the dose, and it looks like we're still getting excellent effectiveness. So I think that's really encouraging. And then I'll turn it over to Robin to address the first half of the question.
Thank you, Shannon. So if I understand the first question, it was how the 12 to 18-year-old uptake can inform the age 5 to 11 group. Is that correct?
Yeah, when comparing intention versus vaccination rates.
Thank you for that. So our study looked at parents' intentions. So we were able to capture children's direct intention for themselves. However, looking at what research is showing and across the nation, there are studies out there that are looking at children's intentions for themselves. We also, in our second survey, are asking parents about, what is the age that a child can make a decision for themselves to get a COVID-19 vaccine. And one of the things I think we've learned from our study to tailor what we've learned about intention and uptake for our 12 to 17-year-olds is really about informed consent, informing children in the process to make that decision about getting a COVID-19 vaccine. And one of the most significant aspects is making that vaccination easy and accessible to parents and for children of the younger cohort. And maybe that is parents and families getting vaccinated together.
I'm just going to circle back again because I think Robin's bringing up a really good point. I think if we had, in an ideal world, if we could have had families coming in together to get vaccinated where, there was enough vaccine and everybody was eligible, I think some of these issues with uptake would be resolved, because any of us who are parents know what it's like dragging a younger sibling along to an appointment for an older sibling, and you've got to do something with a younger one. They're not eligible. They have to mask, they have to, et cetera, et cetera. So unfortunately, that's a situation we couldn't control, but, it's sort of figuring it out as we go along a little bit.
Fair. The next question is, how do we reach these influencers, especially those beyond health? And how do we get to teachers, spiritual leaders, and others to equip them with the best available evidence?
Shall I start? Yeah, I'm probably going to repeat a tiny bit of what I said before, which is it's important that you don't just involve these people at the tail end of the work, because that's a very paternalistic approach to say, here I am, the expert, coming to tell you that this is the message you have to give your community. It's really important that they're engaged early to find out, okay, what are the questions and concerns of your community? What information are they looking for? Not here's the information I think they need, but what is the information they're looking for? And again, the Métis Nation of Alberta, I've mentioned before because they're doing such great work, but they've been holding, for instance, bi-weekly Zoom information sessions that are not experts coming and giving a presentation to people. They're experts sitting on a panel and people coming and asking their questions. So there's leadership within the Métis Nation of Alberta present. There's experts present, and then people come and bring their questions. So I think it's really this idea of community-led information gathering as opposed to expert-led information sharing. I think that's really a critical aspect.
Great, thank you. Robin?
I'll just add on to, as Shannon mentioned, just the engagement piece and the critical importance of having that engagement from the very beginning, community-led as well. Also, another aspect is multiple avenues of messaging. I think to recognize that people are gaining information from all different areas, whether it be online or news outlets or conversations with your neighbors or in the schoolyard waiting to pick up your children, and just recognizing those influencers, the importance of normalizing of the situation of the COVID-19 pandemic and what we can each do individually to help the prevent of the spread of the disease.
Great, thank you. There's the next question. Has there been any research on changing intentions over time with regard to vaccine? And did we notice any specific drivers that got us from 63% to 83% for the 12 to 17-year-olds that we can begin to apply?
Well, we're very excited to receive back the results of our second survey, because what we've done is we've recontacted the people who filled out the survey in December, who, their children weren't eligible at that time, but they stated their intention. And now we're asking them, so did you get your child vaccinated? If not, are you planning to? What influenced your decision to get your child vaccinated? Or what experiences did you have when getting your children vaccinated that may actually influence their decision for future children. So an example would be if somebody took their 12 to 17-year-old in to get vaccinated and had a really negative experience, whether it was a discrimination issue, whether it was poor pain management or poor communication or whatever, if we can capture that information and then make sure that we remedy those issues for the next rollout for this younger group, I think that's really going to be critical. The issue of, how can we manage to get from 63% intention to 83% uptake? The time we were doing the intention survey, parents knew nothing about, what the vaccine would be like, how safe it would be, how effective it would be. So my initial response would be, parents learned more as they went along and developed confidence. Robin, did I miss anything there?
No, I was just going to say the 63 to 83, I think we can see as a success, recognizing that information sharing, that more individuals were able to go out and feel confident and comfortable to get their children and themselves vaccinated.
That brings us quite nicely to the next question. First of all, Emily says, thanks for an excellent presentation. When we think about barriers to vaccination, we often underestimate the power of the fear of needles have on many children and parents. Do you have a sense of how much this fear might have factored into the intent to vaccinate, the rates of intention to vaccinate that you showed earlier?
We didn't specifically ask back in December about that. We are asking in the second survey that's in the field right now about that. But I think I'll sort of reference back to some earlier work that myself and others have done. There's a couple of really actually world leaders in this field in Canada. And we do know that both the pain of vaccination, but actually the anticipation of pain and the anxiety around pain are a real issue. And the 12 to 17-year-old age group, that's the exact group that are getting vaccinated with HPV vaccine and hepatitis B vaccine and meningococcal vaccine in schools. And we know that anxiety and concern about immunization pain is a big issue. And there's some great strategies. I don't know if any of you are familiar with Anna Tadio's work or Christine Chambers. They both do fantastic work focusing on pain management. So distraction strategies, other pain mitigation strategies like numbing cream. So some provinces have really gone ahead and really moved forward with some of these strategies. I know myself, when my child got vaccinated, we got a message saying, if you think that pain is going to be an issue, you should get some of this numbing cream in advance. So I think there's a lot of proactive things that can be done.
Oh, great. On that note, Children's Healthcare Canada is a co-lead for the Solutions for Kids in Pain, and I'll stick the link in now. And that's also co-led by Dr. Chambers and involving Anna Tadio. So thank you for that. The next question is, where have I got it? Did you gather education level when you were looking at issues around social determinants and intention? Was that a factor at all?
This answer, yes, we did include a significant number of socio-demographics, including education level and employment, income. Unfortunately, I guess that's something we should have, sort of shown the different variables we'd ask for socio-demographics. It wasn't significant in the adjusted model of the actual level of education. Again, as described in the presentation, part-time employment was significant for low vaccination intention.
Great, thanks. Let's see. Linda states she thought the question around pain management was a great one. And she's worked in mass clinics for COVID. And what starts out as hesitancy about the vaccine is really anxiety about the needle. And that has shifted a number of decisions, it would appear, and used many of the strategies that Dr. Chambers through SKIP is promoting. And let's see what's here. Can you offer any other strategies to engage underserved communities? I absolutely appreciate the integrated knowledge mobilization approaches that you're having, where folks are involved right from the very beginning. Given that we're about to roll out the 5 to 11-year-old vaccines, and some communities may or may not have been engaged already, what strategies now can folks enact to help boost immunization rates in those communities?
If it's okay, I'll maybe just make one comment about schools, and then if Robin has anything else to add. When I was thinking about this, the 5 to 11-year-olds are quite literally our elementary school kids. That's, almost all kids go to school, and that's an environment where they spend a big portion of their day. So I think really, if we could employ some strategies within the school environment that Robin referenced the idea of normalizing it, that this is a normal thing to do, that we can deal with the issues of concern about pain. My own daughter's about to get HPV vaccine, and her best friend is very nervous about getting the needle. So I think if we can have strategies within the schools to really tackle this, then it ensures that populations where maybe the parents aren't as, on the internet and reading things, or they don't have the opportunity to listen to educational sessions or whatnot, but taking the message straight to the kids in the schools, I think could be a great strategy.
That makes a lot of sense. Have you been doing work in the schools or with the schools at all, or know of anyone who is?
I don't. I'm not sure if Robin does, but I think it would be important. We're certainly in the survey, we're asking whether or not parents are, okay with their child getting COVID vaccine in school,
right.
As a strategy. But Robin, anything to add about reaching this group?
Just our Bachelor of Science of Nursing program, we do go into elementary schools and teach safe hand washing and, prevention of COVID transmission. And it's quite an exciting program to see the kids right now in that 5 to 11 age group sort of grasp that concept and want to be a part of the solution. So that's one aspect that's interesting.
Yeah, go ahead. No, go ahead.
I was just going to jump onto the other part regarding underserved populations. I think from the literature, the key message is to meet individuals where they are at, maybe whether that be physically or whatever else is going on in their life right now with multiple children or whatever social demographics they're facing, and that being on site within communities where that relationship and that trust is built again from the beginning. And that's really the key message for reaching underserved population groups and serving them well.
You're getting some comments in the chat box sort of encouraging that particular approach. You mentioned earlier in the presentation around the COVID vaccine being seen like the flu shot. How do we make people rethink vaccines in that way?
Can I take that one? It's interesting. We were quite surprised about that finding regarding COVID vaccination intentions similar to influenza vaccine uptake. And I think this leads back to the H1N1 pandemic as well, where a lot of individuals' intention was related to their previous influenza vaccination.
Right.
I think the important piece, and this is something our second survey is getting at, is trying to promote the idea of, we keep talking about when the pandemic's going to be over, but recognizing that maybe what we need to start looking for is how are we going to maintain and manage, a society and environment where we have a virus that may require annual or frequent, they're calling boosters or third doses, and start to recognize that this is something that we need to do as a society to keep us safe.
Yes, we could be in this for a while. Linda also comments that she's worked with N2 Canada and the Child Study, creating cartoon videos that were meaningful for knowledge mobilization tools for children. Parents' feedback confirmed that the tool is very helpful for uptake. Are there any available strategies like those that you're aware of?
No, I'm not. And I'm coming out of this webinar thinking, gosh, why don't we have direct to children information available? I'm not actually aware of any great videos or tools out there. We have tended to focus on this communication to parents.
Understandably.
Yeah, which, ultimately, especially for the younger kids, they are the, prime decision maker for children. But if pain, anxiety, and questions and things like that are impediments, that's coming from the child. And so we need to address that with the children. So I know I'm going to get off this call and start thinking about what could we do? Is there messaging we can get into the school? Are there videos we could be developing? So you've just created a bunch of work for me.
Sorry, but yeah. The work is never done, is it? Well, I want to thank you. I think that's the end of our questions for now, unless you had any last minute sentiments to share.
I think, I don't actually know who's on the other end of this webinar, but if you're in a position where you can, where you are an influencer or whatnot, just, I think, again, getting that message out that, the vaccine has been tested in children and has shown to be safe, and that 2 million 12 to 17-year-olds have been vaccinated in Canada. Because I think if parents understand the vaccine a little better, there'll be less hesitation about getting their children vaccinated.
Yeah, there's certainly evidence around vaccine confidence and vaccine hesitancy around the safety and efficacy being the main set of questions that families have.
Yeah. Any parting words from you, Robin?
No, thank you so much for welcoming us here today.
Oh, thank you both for sharing your time and expertise with us. Thank you to all our members and other attendees for choosing to join us. And we know how busy you all are right now, and we hope you depart with some practical knowledge to bring back to your organization. Join us for the rest of our October Spark Live webinars, still in keeping with the theme of vaccines for children. On October 27th, we're offering COVID and Kids, the case for vaccinating younger children in Canada. Children's Healthcare Canada's November Spark theme month is based on pediatric pain management. And on November 10th, join us at 11 o'clock for pain for children with severe neurological impairment, how to get to tomorrow. And on November 17th, also at 11 a.m. Eastern, pediatric pain, patient partnership, and research, 5 studies to keep you in the know. As well, we invite you to register for our 2021 annual conference taking place virtually this year from November 22nd to 26th. The theme is From Crisis to Catalyst, the next chapter for children's healthcare. It's always great if you can watch live, as your questions and comments enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks for joining us today. Thanks to Dr. Shannon Mcdonald and Robin Humble for this presentation. And hopefully we'll see many of you back here on October 27th. Bye, everyone.